And next up, we have Tyler Seibert, who's going to talk to us on whole body MRI for metastases. A little bit of a challenging topic. I hope you can convince me that it's really useful.
I won't. But we can start with something. So disclosures, a few examples of why we might consider this something that deserves more study. So case one is a 63-year-old with Gleason 4+3+5. PSA was quite high, clinically T2A, and he had a radical prostatectomy. This was 4 years prior to current discussion. There was no extracapsular extension. The margins were negative, so all good so far. But post-op PSA was 0.8. That's not so great. PSA rose slowly. Patient declined treatment, kind of in and out of follow-up. Now 1.5. So he got, before I saw the patient, had a PSMA PET, was read as positive for this tiny lesion in the right iliac bone, and was referred to me as a radiation oncologist for metastasis-directed therapy. Now, we've talked about false positives. The nuclear medicine physicians in the room may be looking at this with some suspicion. I did as well. So I ordered an MRI and a biopsy. MRI because I was thinking about treating the fossa anyway, and a biopsy, a CT-guided biopsy. They tried, it was negative. IR called me and said, I'd like to try again. Well, it was really small, maybe I missed it, but I think I can get it. He tried again, and it was benign again. So, no metastasis, but the MRI, meanwhile, showed a lesion in the fossa. And then I get a call, treat the fossa, boost that thing, there's a lesion. But MRI is quite useful, as we know, for primary prostate cancer detection. And if you look at that, it looks benign. And sure enough, it looks like BPH. And we biopsied it, and it was BPH. And that could explain that growth. So there was some prostate left behind on the prostatectomy, which hopefully is not super common. But in the early days of robotic surgery, some of the surgeons were leaving some tissue behind. So we could have treated that patient as metastatic, but instead we treated him not at all, and he doesn't have any sign of cancer. Second case, 60-year-old, PSA only 2.0, PIRADS 5 lesion, Gleason 8, got a PSMA PET. He had one small node that was avid on PSMA PET. We put him on a trial. He was randomized to intensification with apalutamide, and then started to do the planning for radiation, at which point I got an MRI. So here's the the pre-ADT PSMA PET, no lesion, MRI done for treatment planning after he's been on ADT, and the radiologist says, I see two suspicious lesions in the bone. So you can see them in the right pubic ramus. 2 lesions. Well, that was terrifying. So I went back and looked at the old MRI that had been done before he started ADT, and they were there then too, but they were overlooked, probably because the PET was negative. So everybody blew them off. Now, if you used our advanced restriction spectrum imaging, advanced diffusion MRI, I think we wouldn't have missed those. This is a research project, but I regret not having that available at the time. So we got a new PSMA PET, and now one of those 2 lesions is positive, only one of them, and the patient has a spine met that's new. So there is something to think about. MRI has some potential utility in metastatic disease because it doesn't care about what's being downregulated or expressed or any of those things. It doesn't care about what kind of cancer you have. It just looks at cellularity, and it distinguishes cellularity from fat or from normal tissue. Prognosis is interesting with whole body MRI. We heard a little bit about that yesterday. Early assessment of treatment response we'll hear about in the next session, so I'll skip those. We also discussed yesterday about some of the reasons why we're not getting it. I'll mention one of the reasons is it's hard to get funding for trials for MRI because there's not a company that has much motivation to pay for it, right? So we have more data on PET, which I do think is the standard of care and is available. I'm not going to convince Dr. Hoffman that he should change his career, but it is worth remembering that there might be something to it that we haven't learned because we haven't looked to cite Dr. Hoffman. So instead, I think I'll focus a few minutes on the Achilles heel of all imaging, since we're lacking data on whole body MRI and what it really can add. Think about the future and what could we do. And the Achilles heel of all imaging is cancer is in the eye of the beholder. It really matters who's looking at the scan. So if you think about MRI diagnosis. This is a study of 26 institutions. They looked at if an MRI called it positive, the patient went to biopsy, what is the probability that the patient was diagnosed with a cancer, a clinically significant cancer? And you see that at one institution, it's less than 20% chance, and at another, it's 70%. The red lines are within institution cross-radiologist variation. So it matters which radiologist read your scan. Now, if you showed this to patients when you order that MRI, and you tell them, we have no idea where you are on that or where you're going to go or who's going to read your scan, they'd be horrified. I mean, it's almost, don't worry, MRI does work on average, but there is a big problem with variation. So my background prior to clinical training is an engineering PhD and focused on quantitative MRI. And if you think about the physics and the biophysics of MRI, what we use for finding cancer is diffusion-weighted imaging, right? ADC and DWI, that's the main thing for finding cancer on MRI. But we use curious mathematics for that. ADC assumes that the water molecules are moving like a drop of ink in a still glass of water. There's no tissue, it's just moving. And that doesn't make any sense. We know it's much more complex. What we really should be thinking about is water that's inside cells, water that's trying to get around an extracellular matrix, water that's diffusing inside the lumen of a gland, and water that's moving in capillaries. And if we do just a 2-minute scan, 2-minute series, a diffusion series that's a little bit more thoughtfully programmed, on a conventional current standard of care MRI scanner, and then you mathematically resolve those signals, you can make a map like this on the right where you're really highlighting just that intracellular restricted diffusion that represents cancer. And the goal is to try to make non-experts good. So non-experts like myself, radiation oncologist. We had 44 radiation oncologists on the left, tried to circle tumors for targeted treatment. We told them where it was. We said the radiologist said there's a 1.1 centimeter PIRADS 4 lesion in the left anterior gland at the base. The mid gland, right? In the peripheral zone. That's where it is. And then we asked them to draw it on conventional MRI, and they missed. 18% of the time, they didn't have a single pixel overlap with the true tumor, right? But when we give them the RSI maps, they had no problem. And in fact, they saw the RSI map a month before they saw the conventional. So they forgot where the tumor was, so to speak. So we need to do that at a bigger scale. So we took this information, we took our new RSI imaging, and we started bringing it to more places. We found this, developed this consortium, Quantitative Prostate Imaging Consortium. We pooled data. Here's using it as a biomarker. So take the prostate. Don't depend on which radiologist found the lesion. Instead, just identify the prostate with AI, so just to outline the prostate, and tell me what the RSI max, think of it like SUV max, of the whole prostate, no lesion detection required. And that value tells you what the probability of finding cancer is, right? And it's quite high if the RSI value is high. And not only is it high, but because I don't actually believe that most of the grade group 2s are clinically significant in the sense that they're going to progress to metastasis and death, we're looking also at grade group 3, 4, and 5, which are the ones that are more clinically urgent, if you will. And the performance of this as a biomarker independently is on par with the yellow curve, which is PIRADS. So just a single voxel without any interpretation by humans is already doing about as well as multiparametric MRI by humans with only a 2-minute scan. We tried looking at this in whole body, so back to topic. We're supposed to be talking about whole body MRI. Here's a patient, CT and bone scan. We didn't have PSMA PET available in San Diego. That's my big regret, that when we ran this study, we couldn't do any comparison. But anyway, we didn't have it at the time. So here's CT and bone scan. Patient was read as normal, but on whole body RSI, clearly had a metastasis that was biopsy proven. And we ended up treating that. Here's another bone scan that was read as equivocal, probably degenerative disease, whole body RSI, extensive disease. This was neuroendocrine. Who knows what it would have looked like on PET? But obviously changed the management for this patient. And that was all biopsy proven as well, including the sternum. So conclusions, we should use MRI as a complementary tool to PET. Exactly how to do that, I'm not sure yet, though I don't think we know, but at minimum, we should look at the bones and the pelvis on the MRI scans that we're already getting and not blow off findings that weren't concordant with PET, because there may be something there. at least be thoughtful. We should incorporate whole body MRI into therapeutic clinical trials because we're not going to know unless we collect the data. And also, I would argue that the future of imaging is quantitative. I think that we're moving that direction in PET, and I think in MRI we have strong data that we can do that as well. And accurate diagnostics should be available everywhere. Here we are, APCCC Diagnostics. It's critical that we figure out a way to make these things available everywhere, not just in the people in this room and our patients, and not just on clinical trials where it's experts doing all of the reads. And thank you.